flexion.
My case study was a rugby player presenting with chronic pain 5 out of 10 anterior lateral momentary knee pain, and he has the loss of full passive flexion due to stiffness. And I would begin the subjective exam as the patient walked in through the door, and that would be to assess his gait. Throughout the subjective exam, I would establish the mechanism of injury, what causes more pain, so the axonesis, the sin factor, the history of the knee pain, and the medical history to determine any contraindications. So I would also establish which anatomical structure would be causing the pain. Anatomical structures, so the joints to consider would be the medial tibiofemoral, the lateral tibiofemoral, and the patellofemoral. The stability of the knee complex is provided dynamically by musculature, passively by ligaments, and the screw hole mechanism. The visual analog scale, he's already determined that it's a 5 out of 10. I would determine if he would have any pain, extrinsic and intrinsic, if he's had any history of imagery, what his social history is, the nature of pain, and if there was any lock-in or hyperextension, does it give way. As I would begin the examination, I would ask the patient to do active range of motion, so I would assess him doing flexion and extension from each angle.
Onto the bed, please.
After assessing active range of motion, this would be to assess the patient's willingness to move. I would go on to passive range of motion. I would test each range of motion at the beginning, the middle, and the end. This would be to assess for any clicking or any grinding. I would always assess the uninjured leg first. My short-term goal would be to reduce pain, and my long-term goal would be to have full flexion, would be to reduce stiffness to cause full flexion, passive flexion.
You what?
On the tibiofemoral joint, axes of motion are flexion, extension, abduction, adduction, and rotation. The functional movements are often a combination of these movements. Therefore, I need to consider combined physiological or combination of physiological or a combination of physiological and accessory movements in assessment. The patellofemoral joint has 3 distinct facets: medial, smaller than lateral. The thickest articular cartilage reflects loads transmitted through patella, and it's greatest at 30 degrees of flexion. It would improve the mechanical advantage of the quads. So the patellar positioning is the retinaculum, the ligaments, and the capsule. So the patellar tracking complex has 3 directionals, so it's gliding, superior, inferior, medial, and lateral. I would be testing the patient's knee position and flexion, abduction, external rotation. This would be to compress the lateral, that would allow compression of the lateral condyles. And then I would go flexion, adduction, and internal rotation, and this would cause compression of the medial components. I would do this first of all, I would test the bad side first, and then I would I would test the uninjured side first, and then go on to the injured side. I would start the tests at the beginning of range of motion, so at a 10 to 15 degree angle, and then I would go on to assess it at a 45 degree angle, and then I would go on to assess it at flexion at a 90 degree angle. Flexion is classed as a AP glide as it's concave on convex, so it's going in the same direction.
being quiet. Fine, but that's my own drink.
This kid's pushing your pants.
So what?
Pushing it.
I wasn't.
In full extension.
I would also apply traction, and I would also do a pull down longitudinal glide. I would then go on to test the patellar femoral joint and ask the patient to lie supine on the bed. Firstly, I will palpate the borders of the patella.
Just so you can kind of see.
My knees.
Yeah.
Oh, wait there. Is it on? You'll have to tell us where to hold it.
Yeah. Down a bit. That'll do, yeah. And then I'll go on to the next leg.
Keep an eye on it.
So I will firstly hold the borders of the patella and try and lift it up. This is compressing.
So compressing.
I will then hold the borders of the patella and try and lift it up. This is distraction. Compressing would be pushing down. I would do a superior glide, which would which would consist of me pushing the patella up, and then I would do an inferior, which would be me pushing the patella down. I would push push in would be medial, and a push out would be a lateral glide. And that would be in, I would also do the same in external and internal rotation. The treatment progression, the soft tissue technique I would use would be soft tissue release, and that would be on the hamstrings and the quads. The dosage using Maitland's principle would be a grade range of motion of 3 times 30-second oscillations, and if acute, 6 times 15 oscillations. I would use transverse friction on the patella tendon, and I would use a PA glide on extension and an AP glide on flexion. This is Maitland's principle of grades, so grade 1, grade 2, grade 3 and grade 4 on both legs, the uninjured leg first.